guys, welcome back. The next topic we're studying is intracranial space occupying lesions, where the first one that I will explain to you is neurocysticercosis. This is an important cause of intracranial calcification. Yes, a CT head is very good for intracranial calcification, but the point is that the calcification in this disease will occur in the later part of the disease. If the MCQ says, what is the preferred imaging modality for this condition? Then please remember, do not answer a CT head with or without contrast. The point is that neurocysticercosis, after all, will be having larva growing in the brain, so they will always be an associated vasogenic cerebral edema. And if I want to evaluate this vasogenic cerebral edema, obviously along with the parasite developing in the brain, I need to give a contrast. Now the contrast uptake definitely occurs in some parts of the brain which are outside the blood-brain barrier, but if there is going to be vasogenic cerebral edema, then even those areas which are, I would say, covered by the blood-brain barrier. You are aware blood-brain barrier is composed up of the foot processes of astrocytes. So uptake of contrast will occur in those areas where traditionally it does not happen. Therefore, if he says what is the imaging modality of choice for diagnosis of this condition, your answer would be given as gadolinium enhanced MRI. And because I have seen a lot of students messing up on this one, so I thought that I should rather start this discussion by highlighting this fact right away. The objective is to identify not only the parasite developing in the brain, you not only can see the scolex, but you definitely have to demonstrate the vasogenic cerebral edema. And this is the reason why these patients will be having seizures, because the cerebral edema will contribute to inflammation of the brain parenchyma. And that also explains that when you start the treatment of these patients, you don't right away start with albendazole. The first treatment that you will give to these patients is dexamethasone. You would give steroids to these patients to minimize the vasogenic cerebral edema and reduce the frequent episodes, or rather reduce the frequency of seizures developing in this patient. I would now like to highlight on this image of tapeworm that is developing in the gut of an individual, and don't be under impression that tapeworms will be found only in non-vegetarian people, even in vegetarians as well. The length of this worm can reach up to 3 meters. And you can see these small segments that can be seen. In fact, I'll just like to highlight it. These segments that you can see here are the ones which are taught to you in microbiology as proglottids, and they're very sticky. So if a person who is relatively unhygienic, when he goes to the washroom, when he will defecate, these proglottids might be sticking to the perianal skin. And when this person will wash his perianal area after defecating, if he does not wash his hands properly subsequently, there's a high possibility that he will be ingesting these proglottids. And once they are ingested by this person, then you can imagine the unhygienic situation that I'm talking about. Then this person will definitely be having adult worms developing in his gut again. Where does this worm live? It is not the large intestine, it is the small intestine, and then he'll obviously give you options like duodenum, jejunum, and ileum. So tapeworm would be living in the upper jejunum, and the proglottids are highly sticky, and therefore there is a distinct possibility that unhygienic circumstances will increase the incidence of this person transmitting the infection. Like if it's a mother or a father feeding the child, then even the child can get infected, or these patients can infect themselves as well. You see, what I want to highlight is that the standard impression is that only non-vegetarians would be developing it. I want to highlight that even vegetables which are grown on fecally contaminated soil. You see, if vegetables, especially the ones that I'm talking about are cabbage and lettuce. In fact, I would just like to jot down the names also. You see, leafy vegetables like cabbage and lettuce, which are components of salad, and if they're not washed properly, especially in street food, there's a distinct possibility of patient getting the infection. I also highlighted the role of poor personal hygiene. So the nails of this patient are jet black and dirty, and this person does not wash hands after going to the washroom as well. Now, if a person is consuming pork which has not been cooked properly, it is a semi-cooked pork, then what he is ingesting is actually the larva. And when these larvae will go inside the body of this person, that is inside the GI tract, they will obviously go and then mature into adult tapeworms. In fact, the question that was asked in the exam was that a person who is consuming pork, what will it develop? Will it be cysticercosis? Will it be neurocysticercosis? Or it will be intestinal tapeworms? Please remember, if somebody is ingesting the larva, not the eggs, then the larva will obviously develop into adult tapeworm in the GI tract of the patient. This person is not gonna develop neurocysticercosis. Yes, these larvae can definitely migrate out. Via the bloodstream, they can reach the muscles of this individual, and therefore this relatively, I would say, a person belonging to the lower socioeconomic state of the society, this particular person will start developing lumps or bumps in the skin. I want to highlight that when it comes to patients of neurocysticercosis, these lumps or bumps are actually going to be intramuscular, so they will be having a limited mobility, unlike a lipoma, which is relatively having and is freely mobile in all directions. And lipoma will usually have predilection to upper back, but in this case, you would be having these, I would say, nodular lesions that you can feel in the muscles, even in the extremities, in fact, all over the body of this person. I'll also show you a very peculiar, rather an X-ray of an individual who had cysticercosis, and he was having this calcification around the dead larva, which was visible in the X-ray in the form of a rice grain calcification. A very interesting X-ray coming up subsequently, guys. The word is rice grain calcification. That is because of cysticercosis. But as you can see from the discussion, I'm trying to highlight and explain to you the fact that the larva cannot cross the blood-brain barrier, so you are not gonna have a neurocysticercosis in this chap. Then, how are you gonna get neurocysticercosis? Well, one of the important reasons is this person is a pure vegetarian, let me say. He is eating vegetables that were not washed properly, and these vegetables were grown on fecally contaminated soil. So what is ingesting into his body is the eggs. And these eggs via the GI tract will then obviously go in the bloodstream, and then subsequently they can go into the brain, and then they would be larvae developing in the brain of this guy. Similarly, if a person is having poor or personal hygiene, and under the nails of this person are again the eggs. So you can see that now I'll try to unite the two arrows here to highlight that a person who's ultimately consuming the eggs is the one who would then be getting infection in the brain, because these eggs will come via the GI tract into the bloodstream, then cross the blood-brain barrier, hatch into the larva, develop in the larva in the form of larva, and you can actually visualize the scolex on an MRI head of the patient. And then in the later stages, when the immunity will kill the worm, then in the same patient you will also be having is a evidence of intracranial calcification. Therefore, the message is that in a non-vegetarian individual, once he is consuming this semi-cooked pork, he will not develop neurocysticercosis, but will end up with development of adult tapeworms. Now I will be describing a case before you as they gave in the exam. This is a person from low socioeconomic state of the society. Let me say this guy is a rickshaw puller, and he has been having multiple episodes of focal seizures since last couple of weeks. Initially, he went to some RMP kind of doctor in the slum only, and he prescribed him whatever medication that he was aware of, and unfortunately his episodes have not stopped. They are still continuing, so he decided to come over and show at your government hospital. The message here is MCQ wise, what is the type of seizures seen in neurocysticercosis? It is not GTCS. Majority of patients present with focal seizures, and it's not going to be one, it's going to be recurrent episodes, because as I explained to you, there's going to be presence of vasogenic cerebral edema that will irritate the brain parenchyma, triggering these seizures. There can also be a history of Jacksonian march that could be given in this case, like the involuntary movement started in the thumb, then in the fingers, then at the wrist. So the involuntary movements might spread from the distal part to the proximal part. The word is Jacksonian spread in this case. You will now be physically examining this patient. So you initially found that the GCS of this guy was fine. You see, I want to highlight the fact that this particular disease, when I say neurocysticercosis, it can affect not only the brain parenchyma, it can actually affect the ventricular system as well. So in the later stages of the disease, you might even be having evidence of raised ICP. The technical terms that you will study, and I can add to this discussion from the microbiology domain, will be that you might read about cysticercosis cellulose, and another term that you will read will be cysticercosis racemose. I want to highlight the fact that when you read about cysticercosis cellulose, then this is going to involve mainly the brain parenchyma and contribute to cerebral edema. It is also going to contribute to cerebritis. Both of these, cerebritis and cerebral edema, will explain the seizure episodes. But if you read the word racemose, it basically implies that the worms are developing, or the larva is developing inside the ventricular system. They can actually physically block the ventricular system and thereby result in development of a raised intracranial pressure and even a hydrocephalus in the patient. So evidence of raised ICP may or may not be given. That is dependent on whether you are having the development inside the ventricular system or whether it is predominantly a parenchymal involvement. I have put double stars in front of parenchymal involvement just to highlight the higher incidence of cerebritis and cerebral edema in this patient. So when I examined this guy, let me say this guy per se, the GCS was normal. There was no cranial nerve palsy. The cranial nerve examination was within normal limits. I checked his deep tendon reflexes also. So the knee jerk, the ankle jerk, the bicep jerk, they were perfectly normal. But when I did a fundus examination, I did find evidence of papilledema, and I'm writing plus minus in front of it because lots of cases actually the papilledema component may not be there. But I noticed two things which were very characteristic of this individual. One, he was having these lumps and bumps. In fact, he himself pointed this out that, sir, I'm having these swellings all over his body. Or I, on my general physical examination, noticed that there were multiple lumps and bumps all over the body of this person. And second, I want to highlight that since he has had a focal seizure in the morning, he might be complaining of weakness of one of the hands. See, he's a rickshaw puller. He's dependent on his daily earnings. So when he's driving the rickshaw, suppose he has to apply the brakes. Now, if you're having weakness in your hand, he will not be able to put on the brakes. So he might actually come to you. Why? Because he cannot drive the rickshaw. So there is a possibility that post an episode of focal seizure, this person might be having a weakness in one of the hands, a focal neurological deficit, and his main problem is not the episode of seizure. He thinks that, okay, this has happened, low socioeconomic, low education, he might be neglecting his illness because he needs food on the table every day. So his primary problem is that I can't drive my rickshaw because I'm having my weakness. Now, I have decided to admit this guy and do a workup of this individual. And for the workup of this individual, as I highlighted before you, it is a gadolinium enhanced MRI, which is the investigation of choice. But in the MCQ, if he says, what is the first test to be done for this patient, don't straight away answer an MRI head. I would definitely like to have some evidence of neurocysticercosis by performing a lumbar puncture, obtaining the CSF and testing it for neurocysticercosis antigen. The investigation, the first one to be done in this condition is a CSF immunoblot. Do not answer CSF ELISA. Your primary answer would be, because the sensitivity is relatively lesser, your primary answer for the first investigation is CSF immunoblot for neurocysticercosis antigen that must be demonstrated to be present. So you are having antigenic evidence of the infection. Then you will be performing the preferred imaging modality of choice in this condition, that is a gadolinium enhanced MRI, and this has been asked multiple times, though you can definitely pick up the starry sky appearance here, but I would like to go beyond the starry sky appearance. You see, what's going to happen most of the time in the MRI hit that is given to you would be, and I can just draw arrow to highlight one of the findings and then subsequently I'll explain it. Like you can see this black spot here that I've just highlighted. So lots of time in the exam, you would be having an MRI head that will be showing a black spot that is a hypointense lesion. In some cases, however, there's a possibility that inside this black spot, there might be a white spot seen. So I'm highlighting black, and that inside the black, there would be a white spot that is seen. This white spot that is seen is actually the scolex of the developing larva. And as the lesion will progress, so I am now modulating the diagram slightly to show before you that there is a possibility that around this lesion there might be a grayish area present. In fact, in the exam, he might give you a plain MRI and a contrast MRI side by side. So first you will do a plain MRI, then you will obviously push in the contrast, and that is when you will be able to demonstrate the cerebral edema component. So in a same patient, there might be various type of lesions present. Some of them are the ones which you will casually call as hypo-intense lesions. You are very much familiar that in CT scan, I was using the word dense. I was using the word hypodense and hyperdense, but in an MRI, I'm using the word intense. So hypo-intense lesions would be seen initially. You can visualize the scolex. There might even be evidence of cerebral edema. Now, in the later part of the disease, what's going to happen is that the immunity will try to actually kill this worm. So I have now shown the worm disintegrated. You can see that the worm is disintegrated. The magnitude of cerebral edema might increase even further, and most patients become symptomatic at this stage. I mean, the symptoms obviously started initially. He was feeling unwell, and then the cerebral edema component has worsened in this case. So just put a double plus sign to say the cerebral edema component has worsened and the immunity is reacting against the worm. It is successfully killing the worm. Still, if you evaluate this patient 6 months from now, then the same area will not appear black but will appear relatively white in color, and this would be now a calcified spot because the worm has died. You see, why we are studying this is because if a person is having only intracranial calcification, all the spots are jet white, that basically means the worm is dead. In those circumstances, you just need to give this particular person antiepileptic drug treatment. There is no need for albendazole, but if I demonstrate the live worm, then I definitely need to give albendazole to the patient to kill the worms. Now, what you need to understand from the exam perspective is that they will try to link up these basic microbiological aspects with radiology. You see, initially, if you are going to be having only these black spots, which are going to be called as hypointense lesions from the radiology perspective, the micropersons are going to call it vesicular stage of development of the worm. The subsequent stage of development is called as colloidal vesicular. In this, the cerebral edema component has started to develop. Then the immunity is beginning to kill the worm. You can see subsequently there is substantial amount of cerebral edema, but the worm is dying. This would be called as granular nodular format. And lastly, if you look at the white spot here, this would be called as a nodular calcified format. So you can see the sequence of events that are originating here. It is vesicular stage, colloidal vesicular, granular nodular, and a nodular calcified stage. That's the sequence of events that will be developing in this individual. And the black spot that is present here is actually the Scolex. I want you to realize the fact that they basically want you to be able to relate the radiological findings with the microbiological stages of development of the worm. The message is, if it's gonna be a black spot, that's the vesicular stage. If it's the white spot, the hyper intense format, then it's nodular calcified, and most patients will become symptomatic at these stages. If he says a person of neurocystic sarcosis is becoming symptomatic at, then it is colloidal vesicular and granular nodular format, when the symptoms of the patient are gonna rather deteriorate, or rather they will worsen. Now in the exam, lots of time they might actually, though what I am doing is slightly deviating from the diagnostic protocol, they might actually incorporate what is technically called as absolute criteria for diagnosis of neurocystic sarcosis. Lots of things that I will now say in absolute criteria may not be very practical and are hardly done in the hospital, but because we are talking about this topic from the academic domain, so it is also a good idea to just have an idea regarding the absolute criteria for diagnosis of neurocystic sarcosis. Like he might say that there should be a histopathological demonstration of the parasite. In fact, you just need to remember these terms from the perspective of having a choice in the exam where these might be mentioned. Histopathological demonstration of the parasite, which should be demonstrated either in the brain parenchyma or in the CSF of the patient. As I said, the cellulose format will affect the parenchyma, the racemose form will affect the ventricular system. So the same thing represented here. Another terminology that you will read will be with respect to fundus examination, because the eggs are gonna spread everywhere. The larva could be developing even with respect to the eye. So they could be subretinal cystosarcosis also written in the question. I mean, that's, if it is demonstrated, then he's trying to say that you don't need to do all of this. I mean, if you're having a subretinal cystosarcosis demonstrated, then it's a confirmed case of neurocystosarcosis. Start treating in the patient. And the third absolute criteria is what I just explained to you, neuroimaging. I hope it is very clear to you. The preferred neuroimaging modalities are gadolinium enhanced MRI. And what are you going to see here is two things. One is going to be Scolex, and second is going to be evidence of vasogenic cerebral edema. You see, vasogenic cerebral edema alone can be present in multiple conditions, no? So you need to get it in the right perspective, that if you demonstrate the Scolex, and most of the time the Scolex will be present slightly in the periphery of the black spot, it may not be exactly in the center. So he might just use casually the term target sign as well, though target sign is what you read in dermatology for multiple lesions like erythema multiforme. But I just want to say that target sign as a word or terminology can also be given. So neuroimaging definitely plays an important role in confirming the diagnosis of this condition, so that you are sure that you are dealing with a case of neurocystic sarcosis and not a tuberculoma. I want to highlight this once again, though I'll show you slides of a tuberculoma as well. Whenever you are going to get a intracranial calcification, it could be a tuberculoma also, since tubercular meningitis is fairly common in our country. So it is your diagnostic skill in the exam at that point of time that you will have to deploy, though I'll teach you how to deploy that to differentiate between NCC versus a tuberculoma. I will now be hand drawing before you a MRI head of this individual. Let us look at the lesions. Though I showed you an image, it's always a good idea to practice what you are gonna see subsequently. And what I'm trying to highlight is the starry sky appearance here. This is the lateral ventricles. Then I'm trying to show some section of the third ventricle. And there would be so many lesions present that you would get tired counting them. And that is the words of one of my students. He said, sir, I mean, just like there are innumerable number of stars in the sky and you can't count them, similarly, the the CT slash MRI head, whatever was given in the exam, was having innumerable lesions. He can obviously give a CT because it's going to be a late presentation for intracranial calcification. But if it's going to be a MRI head, then the MRI head of this patient will definitely be showing evidence of cerebral edema around the lesion. And then I'm going to draw some black spots here as well. These black spots are going to represent the scolex. In fact, if I go back to the previous image, you definitely can visualize the scolex once again. Let us also recall the number of times we have studied this classical term starry sky appearance. You see, starry sky appearance is discussed multiple times in other subjects as well, so it makes sense to just draw a list. You are familiar that if it's going to be lymph node biopsy, then the answer would be given as Burkitt's lymphoma. But if he's going to be giving you starry sky appearance on an ultrasound of the liver of an individual who is having jaundice, then in those circumstances, the answer would be given as acute viral hepatitis. Please remember the fact that even in the discussion of liver, I've highlighted this acute viral hepatitis for starry sky appearance. For kidney biopsy, well, it would be an immunofluorescence study, and immunofluorescence study would be representing the finding of PSGN, that is post streptococcal glomerulonephritis. And when it comes to MRI head being done in an individual, then it is going to be standard neurocystic in fact. So though I know you are aware of all of this, it's always a good idea to practice it. So I just have highlighted the same thing once again. Now I come to the important aspect that I was discussing earlier also, that if a person is going to be having these lumps and bumps in the skin, I am going to order an X-ray of the extremities of the individual. Like in this case, I ordered X-ray of the bilateral lower extremities, and the radiologist gave me a call. He said, "Sir, you want X-ray of both the extremities? Has the patient had a fracture? Do you suspect this person is having a fracture? He came walking, or maybe he was brought on a stretcher. There is no visible signs of trauma." I said, "Boss, I'm not evaluating a case of trauma. I basically wanna evaluate these lumps and bumps." And when the report came, it was very shocking. You can see which look like small cigars, right? This is very particular. These are actually the larvae that have died, and then around them there is a calcification occurring in the patient. So the technical term that I would like to write here is called as rice grain calcification. That is itself an MCQ, and this image was sent to me by one of my students who actually sat for the exam, and he said, "Sir, when this image came without any history, the first impression I got was, is it a gunshot?" Right? Lots of time, no, the Hindi may they use that katta, no? So the pellets can be having a similar kind of an impression, but then the way it was distributed all over the pelvis and all bilateral thighs, I mean, bullet injury is going to be one-sided at one particular spot. In this case, the lesions were diffusely present. So rice grain calcification is a feature that is very characteristic for cysticercosis, and definitely the terminology is important from the exam perspective. This is, however, supportive evidence. You see, this may or may not be present, and my point is that they may not be having substantial amount. The lesions are there, the lumps and bumps are there, but they may not be having a substantial amount of calcification present around them. As a result of which, the classical radiological finding may not appear. Now we come to another important part of our discussion here, which is that we have to differentiate this from a tuberculoma. So he says that you can actually do a MRS, that is a magnetic resonance spectroscopy, by which you can be having a aid to the diagnosis of tuberculoma versus a neurocysticercosis. Well, when it comes to Mycobacterium tuberculosis, one I want to tell you that tuberculomas develop in cases of tubercular meningitis when you give ATT. It is not before starting ATT, it is after giving ATT. So if you're having a patient who was given ATT and still is not improving, he is a diagnosed case of tubercular meningitis, you did a CBNAT on the CSF sample. You have given ATT to this guy, you've given steroids to this guy, but his sensorium is not improving. Why? Because tuberculomas usually develop post the treatment. It could be remembered as kind of a hypersensitivity reaction to killing of the tubercular bacteria by the anti-tubercular drugs. Now, MRS, when it comes to tuberculoma, will mainly be showing spike in the area of the lipids. You see, the point is, MRS is trying to pick up what? MRS is trying, the spectroscopy is basically trying to pick up the products of chemical metabolism. We are going to compare the products of chemical metabolism of Mycobacterium tuberculosis versus the Taenia solium. When it comes to tuberculoma, you will always read in MRS a lipid peak present, or instead of writing about lipid peak, he will write the word choline. You can understand choline from biochemistry. We are talking about lipids here, so he will write the word choline to creatinine ratio spike present in this patient. In case when it comes to tinea solium per se or neurocysticercosis, it's mainly gonna be amino acids. The products of chemical metabolism that will be detected on MRS will be amino acids, then would be lactate, then would be pyruvate. In fact, there has been a question on this MRS findings in the mid-year exam in 2020 also, which was basically highlighting the same fact, and I can just show you the snapshots related to the same so that you can feel more comfortable about it. This was the language of the question. He mentioned regarding a 16-year-old girl with multiple episodes of focal seizures. Though most guys could crack the question on MRI image also, he just tried to make it difficult by mentioning the MRS findings of lactate, amino acid, pyruvate and acetate. As I highlighted, it's always going to be lipid peak when it comes to a tuberculoma, whereas when it comes to neurocysticercosis, it's mainly going to be amino acid. So people can definitely evaluate and answer this correctly. Well, why is the answer not cerebral toxoplasmosis? I have talked about toxoplasmosis topic, especially the cerebral toxoplasmosis component in AIDS per se, but I want to highlight that the lesions of cerebral toxoplasmosis are mainly seen in the basal ganglia, and there must be some information about CD4 count also, which should be less than 100. I also want you to remember the fact that the shape of lesions will also vary. When it comes to a tuberculoma, you will always be having information of patient on anti-tubercular treatment who's not responding to the treatment per se. Well, reason why a person on ATT cannot respond could be actually a question in disguise, where when you give ATT, you know that some of the anti-tubercular drugs are hepatotoxic. So there could be a possibility that there might be a hepatic encephalopathy triggered by the drugs. So please be very clear. If a person on ATT is not improving, first differential diagnosis is it could be hepatic encephalopathy triggered by the drugs. But if that is ruled out by blood ammonia levels and by doing a EEG of the patient, then you must consider tuberculomas, which are usually gonna be bigger. Most of them are going to be bigger and they would be asymmetrical. I mean, as compared to the shape of cysticercosis, the shape of a tuberculoma is grossly asymmetric. So the kind of history that is given will definitely help you in differentiating. And even if you're not able to make a differentiation, just remember the products of chemical metabolism. That is going to be lipids with respect to the Mycobacterium tuberculosis, and when it comes to amino acids, it's going to be neurocysticercosis. So differences definitely would help you in evaluating and would help you get to the right answer. I've given reference of the page of Harrison also where this information is given. That is just to make you realize that he is actually asking standard textbook data. Let's now focus on the treatment which is going to be done in these cases. Don't straight away answer albendazole. Yes, you will give albendazole, but if you start with albendazole right away, the problem is that when you kill this worm, the moment you kill this worm, the products of the dead worm can actually trigger a hypersensitivity reaction. So he says that ideally do not start treatment in these patients with albendazole on a OPD basis. You must admit the patient and load the patient with steroids. The advantage of loading the patient with steroids will be to, first, you will be able to rather reduce the incidence of hypersensitivity reaction. Second, it will reduce the cerebral edema component. The treatment with steroids will subsequently definitely become oral, but initially when he came to me, he was sick, so I have decided to admit him and started him on round-the-clock IV dexamethasone. My objective is to reduce the vasogenic cerebral edema component in this person, and only after 48 hours. This is optional for you, but the point I want to highlight is that don't start the two together. Let the cerebral edema component subside. Dexamethasone will continue for a couple of weeks. It is not that you're giving steroids for a few days in these patients. The steroids will definitely continue for as long as 8 weeks, sometimes might be given even longer. But the point is albendazole will be given in the patient not concurrently but sequentially. Now, what is the duration of albendazole? It is going to be 8 days. Earlier, it was given for longer duration, that is 21 days. But in most of the textbooks nowadays, the duration of treatment is given to be 8 days. Do not confuse with hydrated cyst treatment. No, there also albendazole is given, but is given for 4 weeks. Whereas in this case, I mentioned only for 8 days. Most people tend to focus mainly on albendazole only, but he wants you to mainly remember the treatment aspect with respect to dexamethasone and control of the focal seizures of this particular individual as well. So what are the drugs I can use? The drugs which we can recommend are carbimazepine. If it is a female patient, yeah, I can definitely be more comfortable writing lamotrigine. I have already explained that with respect to lamotrigine, the incidence of neural tube defects will be relatively lesser. How long will you give these antiepileptic drugs? Then it is at least gonna be 2 years. You see, my point is, if you are giving AED to any patient on a regular basis, it is only when the person will become asymptomatic. for continuous 2 years that you can plan to reduce the dosage and gradually wean off the patient of anti-epileptic drugs. I've already highlighted that never stop anti-epileptic drugs immediately. If you do that, the bad news is sudden stoppage of anti-epileptic drugs can actually contribute to the problems in the patient, in a sense that they could be a rebound epilepsy also. The person should be asymptomatic for 2 consecutive years, and then there's going to be gradual withdrawal. When it comes to the prognosis of this patient, yes, I would say that he's definitely going to show a recovery, but the recovery has to be also ensured in a proper fashion, that you just can't bombard him with all the drugs simultaneously. It is like stepwise approach. You first going to handle the swelling in the brain, you come reduce that, then kill the worms, hit them with albendazole, and obviously suppress the seizure component with the focal seizure component with anti-epileptic drugs as well. So if these treatments are followed, then definitely you will have increased chances of recovery as well. In case there is evidence of raised ICP due to the racemose variety, then in some cases even ventricular, this point is just for the sake of completion, I want to highlight that if an adult person is having hydrocephalus due to neurocystic sarcosis with the larva impinging on the foramina which are present in the brain parenchyma, especially in the ventricular system, and they are affecting the flow of CSF, then obstructive hydrocephalus manifestations can occur. So for that, ventriculoperitoneal shunting may even be required for these patients. Most of the time in the exam they have asked the treatment domain. I mean, how would you start the treatment? Would you wait for steroids to be finished and then start albendazole? No. You give dexamethasone, suppress the cerebral edema. After 2 or 3 days, start albendazole in the patient. The imaging aspects I've already highlighted before you, and the importance of MRS is also what I've highlighted here, especially with respect to the products of chemical metabolism, which are lipids with respect to Mycobacterium tuberculosis, amino acids, lactate and pyruvate with respect to neurocystic sarcosis. So if you remember these aspects, you will definitely be able to score right these particular sequence of questions that are being asked in the exam and are very common clinical presentations in our hospitals. The second intracranial space occupying lesion that I'll discuss with you would be brain tumors. Well, let's have a look at some incidence-wise data first. If the question says what is overall the most common brain tumor, your answer would be given as metastasis. And where is it going to come from? So the first primary answer would be small cell cancer of the lung. You are familiar that small cell cancer / short cell cancer exhibits micrometastasis, so it can spread to the brain. Then would be breast cancer, and the third one would be malignant melanoma. So these are 3 important reasons why metastasis can develop. And the next question that I'll put up here will say, what is the most common primary malignant brain tumor per se? You see, there are 2 aspects that I wanted to remember. One is the commonest benign brain tumor versus the malignant one. So the malignant one would be a grade 4 glioma, whereas when it comes to the benign one, it is going to be meningioma. Now, examiners love to ask about meningioma. Why? Because one of the importance, or I would say the relevant facts from the exam perspective for meningioma is it can exhibit intracranial calcification, and therefore because it could be visualized even on a X-ray skull. Look at the surprising thing that I'm saying, that you can visualize a brain tumor with X-ray skull. Similarly, in pediatrics, you would have studied a brain tumor visualized on X-ray skull in pediatrics is craniopharyngioma. So I'm going to explain those details to you as we progress on. Incidence wise, at the moment I have highlighted, it's going to be METs that are most common. But in one of the exams, actually METs were not in the options. Students had to choose between a glioma versus a meningioma. In those circumstances, the answer would be given as meningioma. Please remember, the incidence of benign brain tumor per se is relatively more as compared to a glioma. Points to be remembered for meningioma would be in the following fashion. One I highlighted already, it would be exhibiting a intracranial calcification. In fact, causes of intracranial calcification is itself a topic that has to be remembered. One of the leading causes in India and even global basis is neurocystic sarcosis. Then from pediatric domain, they love to ask about TORCH group of infections. In TORCH group of infections, it is toxoplasma and cytomegalovirus which can contribute to intracranial calcification. Then is craniopharyngioma. This tumor is going to be located near the pituitary, and it can actually even contribute to bitemporal hemianopia. And the fourth one is obviously the agenda at the moment, that is meningioma. So these are 4 important causes of IC calcification that should be remembered. Then incorporating an aspect of radiology here, a CT head is good enough to pick up calcification. The radiological finding that is going to be present here from the radiology perspective is called as dural tail sign. And why the examiner is interested in this is because this brain tumor that is originating from the dura can erode the bone. Look at the surprising thing that I'm teaching you. A brain tumor is gonna encroach into the calvarium. You see, we have an inner table, we have outer table. This is gonna encroach onto the inner table per se. So erosion of the calvarium is gonna be determined or is gonna be seen with this particular tumor. One of the important risk factors for meningioma, in fact, is brain irradiation. Like if in pediatric age group somebody has received radiation to the brain, then there is a possibility that when the same patient will grow up, this person will definitely develop a meningioma. And the association is commonly asked with neurofibromatosis 2. In lot of MCQs, they will mix up this information, and instead of neurofibromatosis 2, they might actually write the word neurofibromatosis 1. I also want to write the statement brain tumor which is visualized, or brain tumor per se, which is visible on X-ray skull, are two of them. One is meningioma and second is craniopharyngioma, and depending on the age group you can definitely answer them. Craniopharyngioma happens to be a supracellular tumor because it's situated slightly superiorly. It's a supracellular tumor in exhibiting a intracranial calcification. One more aspect that I want to highlight here for the radiation component is that if somebody is exposed to radiation in adult age group, then what is the commonest cancer that is seen? This is a miscellaneous question that I'm squeezing in. For radiation exposure, as I've highlighted, the brain tumor that is going to be associated is papillary carcinoma of thyroid. Whereas along with this, in pediatric age group, it can be acute lymphoblastic leukemia, and just now I explained to you meningioma. So these are three cancers that are related to radiation exposure. Repeating that again, the commonest one is papillary cancer of thyroid, then can be acute lymphoblastic leukemia, then can be meningioma. And once we have this baseline epidemiological data in place, we will now study regarding what is going to be the clinical features of a brain tumor. Obviously, it's a mass effect, so it will contribute to raise intracranial pressure. But over and above this, brain tumor can also be having a concomitant cerebral edema. So do not be surprised if the question related to a brain tumor patient might actually begin not only with features raised ICT, but even development of seizures as well. In fact, I can put up a question to you here before I write in the clinical features. Which brain tumor? And in fact, I will ask you this question two times, one for pediatrics and second is for the internal medicine domain. And since this topic is taught in pathology also, so you should be able to answer which brain tumor in adults will be having the worst prognosis. Well, when I was a student at your age, I used to read regarding this term, glioblastoma multiforme. But as of now, this term has been removed. So your answer would be given as grade 4 glioma. But for the older MCQs, do remember the word glioblastoma multiforme. As I've highlighted, even focal seizures can be developing. The reason for focal seizures would be cerebral edema. So if he gives you a scenario that a person with a documented brain tumor is having focal seizures, what drug will you use to control the focal seizures? Then there are many drugs for focal seizures that we have discussed, like carbamazepine or oxcarbazepine or lamotrigine or levetiracetam. If he specifies the word brain tumor per se and says what drug is best recommended, then your answer to control the focal seizures would be given as levetiracetam. Let me explain the reason also. You see, when you look at all these drugs like carbamazepine, oxcarbazepine, most of these drugs have lot of interaction with other drugs as well. You see, when a person is having brain tumor, you would have to give chemotherapy to the patient also. You would be giving steroids to the patient also. So I want to give an antiepileptic drug to this guy that has minimal interaction. Mark my words there. I said I want to give an antiepileptic drug to this guy that has minimal interaction with other drugs. So the best drug is levetiracetam. In fact, when I was teaching you focal seizures for old age, you see, in old age, a person could be having hypertension, hyperlipidemia, diabetes mellitus, may develop enlarged prostate, may develop prostate cancer. So in old age, again, I would like, if a person is having requirement of anti-epilepsy drug, I will give the drug which has the least interaction with all other drugs, and that is levetiracetam. The objective of our discussion is to sensitize you to the fact that though in the list multiple efficacious drugs, I'm not saying that efficacy of carbamazepine will be lesser. Efficacy is going to be the same as levetiracetam. The point is that the drug interaction with antihypertensive drugs, interaction with, let me say, concomitant illnesses that could be occurring in the patient. And like I said, brain tumor patient will anyway be on chemotherapy as well. I want to minimize the interaction. So to prevent the interaction of antiepileptic molecule with other drugs which could be given concomitantly, we are going to use this molecule primarily. Now, let us look at the clinical features, which are going to be very standard. In fact, when you read the topic of stroke, a lot of these manifestations might be given there also, because if there's going to be brain tumor involving the cortex, involving the frontal lobe, parietal lobe, temporal lobe, then the manifestations of frontal lobe damage like aggressiveness, incontinence can develop. If it is temporal lobe, then memory loss can develop in an individual. So standard features would be given. Most of the patients initially would be having difficulty in remembering things, or will be having difficulty in doing routine day-to-day tasks, which will be written as impaired cognition. The person feels tired and lethargic for most part of the day, because these patients actually will say that I have forgotten when I have woken up fresh. These patients are waking up with early morning headache. He will say that when I wake up in the morning, the headache is so bad that I, literally slap my head and I say, oh, I did not sleep properly. Because the first impression of anybody who wakes up a headache would be that, okay, I did not get fresh sleep at night. When you ask the patient, can you point where the pain is present? Most people might, just put their hand like this, or they might put their whole fist over the head and say whole of my head hurts, that is holocephalic, and they might actually have an impression that they are having stress induced headache. So lots of these people might be taking painkillers to no relief. In fact, initially lots of these patients might be misdiagnosed as migraine. So the red flag that I'm raising here is, if you're having a geriatric age group person presenting with migraine like symptoms of recent origin like aura, then definitely your diagnosis of migraine is a big question mark, because migraine is a disease that develops in younger age patients. I repeat my fact, 65-year-old, if I'm diagnosing that, okay, your symptoms are that of migraine, he has been fine all his life. At 65 years of age is developing migraine-like symptoms, maybe an aura, which are visual manifestations in the form of zigzag lines. That tells me the fact that this diagnosis may be wrong. Actually, this migraine-like illness may be a brain tumor which is masquerading, because you see, the problem is the brain tumor will stretch the dura mater. And dura mater is the pain sensitive structure in the brain. That's where the trigeminal nerve endings are present. So that's where the pain component would come. And even in migraine, it is the stretching of the nociceptive receptors of the trigeminal nerve in the dura mater. So that's why the migraine-like manifestations are occurring. As I highlighted, if the tumor is located in the frontal lobe of the brain, he might become aggressive. Like this particular patient might expose himself. He might take off his clothes. He might become nude or naked in the lift in front of people of the opposite gender. This old man, his son and daughter are so embarrassed that my dad was so well behaved all his life. I mean, I've never seen him speak wrong for anybody. And now this guy is maybe committed a sex crime by flashing his private parts at somebody. So personality changes and antisocial behavior might be written in the question. Similarly, if the dominant parietal lobe is involved, then speech aspects can be affected. If corticospinal pathway is involved, there could be weakness developing in a patient, which might be written as monoplegia, would be written as paraplegia, or may be written as quadriplegia. So the initial symptoms of these patients will be a combination of inflammation of the brain as well as raised intracranial pressure, and that leads us to the question that what test should you do in this particular person? Well, the investigational choice for these patients is same as what I taught you for neurocysticercosis, because I want to highlight the vasogenic cerebral edema which is present perilesionally. It is gadolinium enhanced MRI which is the best test for diagnosis of this condition. It will help you localize the tumor. It will pick up the cerebral edema component. And again, I would like to highlight that steroids would be one of the efficacious drugs that would be used even in a brain tumor patient to reduce the focal symptoms that are developing in this patient, because the localized swelling will also contribute to the mass effect, and that's why personality change, aphasia, or weakness was developing. At this juncture, he might even ask you a question with respect to the following aspects. You see, when you are treating this brain tumor, you might be giving chemotherapy, you might be giving radiation. So when you give chemotherapy, the tumor will shrink. Now, if I want to evaluate whether the tumor has shrunk or not, the point is, if you repeat the MRI once again, it's not that the tumor was earlier 2.5 centimeter, now it will become 2.4 millimeter. So you can measure the exact size and say, oh, the patient is responding to treatment. I need to be relatively much more specific. So if he says, how do you differentiate between tumor progression? You see, by meaning of the word tumor progression is that either the tumor could be becoming bigger in size, or it might be becoming smaller in size, on giving treatment, and at the same time your treatment can result in necrosis also, like radiotherapy given can contribute to brain necrosis. So how do you differentiate necrosis versus tumor progression? The logic is, if there's going to be necrosis, then the metabolism will definitely be affected. It will become lesser, whereas if the tumor is becoming bigger, then the metabolism will relatively increase. So to pick up the chemical products of metabolism, the investigation that I would like to do in this case for differentiating would be given as MRS, that is magnetic resonance spectrophotometry. MRS was discussed earlier for even neurocystic psychosis, where I was talking about the products of chemical metabolism related to lipids, which are going to be predominantly with respect to Mycobacterium tuberculosis, amino acids primarily with neurocystic psychosis. Similarly here, it's all about metabolism, it's all about metabolic products. So MRS will definitely help you in picking up the differentiation between the two. The basic word of caution is, if he says how do you diagnose a brain tumor, gadolinium enhanced MRI, how do you differentiate between necrosis versus tumor progression, then it is MRS that would be recommended. Now before I proceed further, I want to highlight some of the syndromes that you tend to read with brain tumor, and this details are actually discussed in pathology as well, but I am using this opportunity to mention regarding where are you gonna read about brain tumors with syndromes, and then also that what is gonna be the brain tumor that would be impacted. So it is Cowden syndrome, von Hippel-Lindau, then Turcot, then is gonna be Gardner syndrome, then is going to be neurofibromatosis 1. So let's have an association, and I've already told you neurofibromatosis 2 is one going to be related to meningioma and acoustic neuroma. Let's have the data. For Cowden syndrome, the tumor that is associated and should be remembered is cerebellar. Now mark my words there very carefully. It is cerebellar ganglioblastoma. But if he says von Hippel-Lindau syndrome, then it will be cerebellar hemangioblastoma. Well, what is the importance of studying hemangioblastoma is because hemangioblastoma per se as a tumor. Hemangioblastoma per se as a tumor is not originating from the cells of the cerebellum, because in cerebellum you start studying about cells like Purkinje cells or basket cells. So here the tumor is not originating from the cells of the cerebellum, it is originating from the blood vessels which are present in the cerebellum. That's why the name is cerebellar hemangioblastoma. In Turcot syndrome and Gardner syndrome, which are read even with respect to when you are reading GI tract as well. So for Turcot and Gardner, one I want to highlight the brain tumor that is associated, which is medulloblastoma. In fact, you read about medulloblastoma in pediatrics also. It is going to be an infratentorial tumor. The additional fact for Gardner syndrome would be that you will read about medulloblastoma plus a tumor in the anterior abdominal wall. That could be desmoid tumors or even osteomas. I repeat the fact once again. Medulloblastomas are going to be read by you in literature about Turcot and Gardner, but association in Gardner will also be, apart from medulloblastoma, osteomas and desmoid tumor, which would be a hard tumor in the anterior abdominal wall of the patient. Neurofibromatosis 1 is a phacomatosis. Seen with this would be rather optic glioma, which can cause a Marcus gun pupil. Neurofibromatosis 2 would be acoustic neuroma, and this I've already sensitized you to. He would definitely love to ask you about meningioma as well. Meningioma is also seen in people after radiation exposure. Then he can talk about tuberous sclerosis. TSC implies Boonville disease, that is tuberous sclerosis, where you read about shagreen patch, you read about ash leaf macules present, you read about confetti lesions present. It's a neurocutaneous disorder where the person will be having epilepsy since birth. When it comes to tuberous sclerosis, then the lesions which are present here are called as SCA. SCA would stand for subependymal astrocytomas, and once we get these informations right, they'll help you score better in the questions, because they love to integrate things nowadays, as you are familiar. So this table is, I would say, one of the highly rated tables that I would like you to remember for this table per se. I shall now be explaining to you regarding pediatric brain tumors, where the first one on the agenda to be remembered is cerebellar astrocytoma. In fact, lots of time the MCQ will begin by saying the word infratentorial tumor. If he says supratentorial, you have to think in terms of craniopharyngioma. If he says infratentorial, you know the location wise inferiorly located. So then it is going to be cerebellar astrocytoma. And the pathologist would have rather used the term pilocytic astrocytoma for the same. Now the point to be remembered, or the point to be understood, is that cerebellar astrocytoma is a benign brain tumor. In contrast, if he says what is the most malignant brain tumor, the primary malignant is what I'm talking about. Then in adults, I was teaching you glioma, but in this case, the primary malignant brain tumor will be answered as medulloblastoma. So one of the important things which are to be understood is that they love to ask about this epidemiological information, and medulloblastoma is famous because of bad prognosis. Mark my words there. I did not say worst prognosis, I said bad prognosis. This tumor will be associated with development of cranioaxial or craniospinal axis spread, and the result of this craniospinal axis spread would be that even the spinal cord would get involved, and that explains why medulloblastoma tends to have a bad prognosis. I've already sensitized you to the fact that he will use the word supratentorial tumor. That is when the answer would be changed over to craniopharyngioma, and this exhibits a calcification, which is why the tumor can be visible even on X-ray skull. That leads us to the inevitable question, which brain tumor will be having the worst prognosis? Now mark my words there. When I was teaching you worst prognosis from adults perspective, I was talking about glioblastoma multiforme, that is grade 4 glioma. This time the answer will be given as brainstem glioma. On listening to this, the query of most doctors is that, sir, we have read that medulloblastoma has one of the bad prognosis, so why are you calling brainstem glioma the worst? The point is there's a difference between the word, I would say, bad versus worst. My point is, brainstem glioma, look at the location, man. It's going to be located near the respiratory center. It's going to be located near the vasomotor center. The critical centers in the brainstem is where the tumor is located. So if you read, especially OP pediatrics, it mentions that the mortality, 6-month mortality rate for brainstem glioma is 100%. That means if you diagnose a case of brainstem glioma today, after 6 months from now, this child would be expired because of the peculiar location of the tumor per se. When it comes to medulloblastoma, I've already explained to you why it is said to be having a bad prognosis. That is, the word is bad is because of the cranioaxial spread, and well, for the superior two details, as I've explained to you, it would be answered as infratentorial, whereas when it comes to the superior ones, it would be answered as supratentorial. Let us also squeeze in information for craniopharyngioma. You can link this up with pathology as well as with the I would say pediatrics, so that you can study the topic once and for all. One of the common questions that is asked on this topic will always in the first choice have embryological details mentioned, that this is derived from Rathke's spouse, so you can definitely read the embryological development. As I highlighted, this tumor will be precariously situated near the optic chiasma, so visual field deficit will occur in this case. So the question will begin by describing a child who has difficulty in copying from the board. Like, he can obviously have medial vision normally, but the temporal vision is hampered in the child. So you will always read about this word, bitemporal hemianopia. Please remember the fact that whenever you read about a child who is having short stature, because he's not going to straight away start with describing features of early morning headache, projectile vomiting, features of raised anxiety, because that gives you a hint that he's probably talking about a brain tumor. So he will talk about a kid who's having poor scholastic performance, and the mother is worried because the child is not able to copy the classwork. Whatever teacher is writing on the board, the child is not able to copy properly. The second problem is that he is relatively a short child in the class. Height less than the third centile is what you know is the definition of short stature. And then he'll also waste your time by mentioning regarding features of central diabetes insipidus in this patient, because the tumor is situated in that area where the posterior pituitary would be located. The damage to the posterior pituitary will contribute to development or damage in the form of central diabetes insipidus. So this child would be having polyuria and polydipsia also. And over and above this, then he will start talking about features of raised intracranial tension as well. So I want you to be very familiar about details of craniopharyngioma, and if you compare the aspects with meningioma, gross contrast would be present. Like in meningioma, I was talking about erosion of the calvarium from inside. I was talking about dural tail sign, so differentiation can definitely be maintained or definitely can be seen. So let us just summarize the important information from both the pediatric and the adult domain that I've explained to you. Like, I have spoken about the commonest primary malignant brain tumor in both adults as well as in children, and instead of just putting tick marks in whatever data that I've written, I would suggest you note it down with me so that this becomes a permanent memory. When it comes to adults per se, just putting alphabet A, this would be answered as glioblastoma multiforme, that is a grade 4 glioma. But from the pediatric domain, the primary malignant brain tumor is the one that would be having craniospinal axis spread, that would be medulloblastoma. In fact, you also studied about Chang classification. That's just a pathological correlate that I've highlighted. And then is a two additional informations that I want you to remember over and above this, which is the important table in Harrison that I'm discussing. The question said, what is the important cause of leptomeningeal metastasis? And the second is a tumor, because the tumor is coming from outside, right? So I'm using the word epidural spinal cord compression. Well, the person can end up with paraplegia if this occurs in the lumbosacral spine. So let's also work up the information for why would this be happening. In fact, I can put this as a question to you guys, because this is taught in surgery also. Yes, guys, leptomeningeal mets, because I will have to maybe do a CSF cytology in this case to identify the malignant cells in the CSF. The answer is going to be given by US, breast cancer. And the same thing is going to be answered for epidural spinal cord compression as well. So remember my facts here, leptomeningeal mets and epidural spinal cord compression is going to be related to carcinoma breast. Then I've highlighted that if there's going to be brain tumor progression, that is going to be maybe a increase in size, or regression means a response to chemotherapy versus the necrosis component that can come up thanks to the radiation that you might be giving in cases of metastasis. You will have to go in for a MRS in the patient. And lots of time there's also possibility that in the images a brain tumor and brain abscess can be confused. But then the point is, in brain abscess per se, if he gives you a air fluid level, great. Even if he does not give you a air fluid level per se, I would say that it will be a circumscribed shadow. You see, a brain tumor will grow asymmetrically, but a brain abscess will be a rather hypo-intense lesion. It would be black lesion, uniform boundaries will be present, whereas a tumor is always going to be asymmetrical. And yes, I agree to the fact that you can say that can't a brain tumor grow in a symmetrical fashion? Yes, it can. So the test that can definitely differentiate between whether it is a brain tumor versus brain abscess is diffusion-weighted MRI. Obviously, predisposition to brain abscess should also be there, no? Like if he talks about a patient of infective endocarditis, he's talking about a cardiac lesion with vegetation going to the brain, then you definitely need to keep a high index of suspicion. Or let me say I talk about a child who's having tetralogy fallet. You are aware that children with fallet's physiology can definitely have TET spells, and following a TET spell they can develop a brain abscess due to ischemic damage to the brain. So there will be some predisposition given in the question as well with respect to brain abscess. Two histories I said, infective endocarditis from pediatric domain, TET spells present are two contributory factors. Or if he talks about bronchiectasis, I mean, if already somebody is having a suppurative lung lesion, then the pus or the infection can spread to the lungs, to the distant areas if the treatment is not given. So there has to be some suppuration or purulent evidence present in the body from where the infection can spread to a distant site like the brain. So brain abscess per se, I think, can be picked up even from clinical history, and whenever in doubt, obviously a diffusion weighted MRI will do the trick for you. Last time I have used diffusion weighted MRI for identification of acute ischemic stroke. I hope you recall that in acute ischemic stroke the findings will take some time to develop, maybe 6 hours by 8 hours, and thrombolysis has to be done within 4.5 hours in ischemic stroke. So I'm not gonna wait for the findings to develop. I will treat the patient empirically, but nowadays is a scenario of evidence-based medicine. So in acute ischemic stroke, for early identification of AIS, ideally a diffusion weighted MRI should be done. So I've talked about DW MRI 2 times. I have specially highlighted about MRS to differentiate between NCC versus a tuberculoma. I've talked about MRS mainly to differentiate between necrosis versus a regression / a progression of a brain tumor. So these are the details for intracranial space occupying lesions. Obviously, they will always be associated with a cerebral edema component. Like if I just say hypothetically this is going to be a asymmetrical brain tumor, then you will always notice on a MRI or on a CT that there would be a perilesional edema present, that is a vasogenic cerebral edema, and the drug that I will use to manage this would be dexamethasone. This has been discussed multiple times that if there's going to be stroke, then we have cytotoxic cerebral edema. But if it is going to be inflammatory lesion present like neurocysticercosis like a brain tumor, we have a vasogenic cerebral edema. Steroids do not have any role in cytotoxic cerebral edema, but steroids definitely will reduce vasogenic cerebral edema. So these are the details that you are basically supposed to remember from the topic that we have discussed. Thank you so much for your patience and hearing me out.